Hi, everyone. Welcome to episode 24 of the HCBiz show, the business of healthcare. We've been doing this show now for a couple of months, Shahid and I, and every week we bring on some experts to talk about a topic that is relevant right now to the business of healthcare, and we try to break it down in a very practical sense. Our goal is always to understand what the issue is, why that issue is, and quickly get to the what can or should you be doing about it right now. We try to avoid hype. We try to avoid things that are just trendy and topical, and get to that meat of the matter. And that's exactly what we're going to do here today. We're talking about patient-generated health data. And of course, everyone's got a Fitbit these days and is tracking something, and it can range up from there all the way up to clinical grade biometric monitoring at home. And there you go, John. I actually don't have mine today. Battery was dead this morning. So it's a very broad topic, and we've brought on some we're stacked with top-notch industry leaders in this space. So I'm really excited to get everybody on. We're also bringing on a fourth here, and I'll be vacating my seat for that. But who we have on screen here right now, Chris Edwards, who is the Chief Marketing Officer at Validic, certainly one of the industry leaders in this space, connecting all of this data to the EMRs and everything else, and making the data move, which is obviously critical to having any success with it. We also have John Sharp joining us. He is the Senior Manager of Consumer Health IT at the Personal Connected Health Alliance, which is under HIMSS. And coming on in a moment here will be Greg Caressi, who is the Senior Vice President of Healthcare and Life Sciences at Frost & Sullivan. So again, top-notch thinkers here in this space. We're going to just set them loose in a moment here. And of course, as always, my co-host here, Shahid Shah, National Health IT Leader, and it seems to be all of these aspects. Always great to have you on, and CEO at Netspective. So I'm really at this point going to hand off to you, and as I said, jump into the sidebar here. So when we do that now, we'll let Greg jump back in. And why don't you start us off and just set us up, Shed? Why is this a topic important? Why are we talking about it today?
Yeah, great. Thanks for that setup, Don. I think you've been doing some great work over these last 22, 23 episodes that we've been working on. And just to set the stage, what we used to call quantified self a few years ago, where people who were basically collecting data about themselves, they didn't really have anybody to share it with. So if you were interested in your own data, you collected it, and then hopefully you did something with it. You talked to a provider about it or something like that. But nobody was really connected from the healthcare systems perspective into that data in the quantified self world. Fast forward now 2 or 3 years, and remember that the guys at Partners Healthcare and folks like Dr. Joe Kvedar and team who have been doing connected health for a little over a decade, have been talking about this for a long time, but it's only been very recent, and with of course help from companies like Validic and Human API and others, that they've been able to get that data, connect to it, and then hopefully present it in a way that can be used by whether it's a full health system or single physician, et cetera. That's what we'll talk about today. But what I'd like to do is set the stage for discussion around the idea. I'd like to talk about continuous diagnostics. What that basically means is that typically in episodic diagnostics, it means that something is wrong with you. You go talk to a doctor, they ask you some questions, and hopefully they might run an imaging test on you, a lab test gets run. But in between these episodes, there's very little known about you. What's going on from a social perspective, what's going on from a physical activity perspective, and whether we refer to as social determinants of health, which are things beyond just your physical patient-generated healthcare data, I'd like to think of that as part of the discussion. So whether it's environmental data that comes in the future, or your step counting data that's coming in today, we are going to refer to almost all of this as patient-generated healthcare data. And when we start talking about the business side with our esteemed panel here, we'll use that, use the entire universe of available data around a patient and how that's going to assist with what I'm referring to as continuous diagnostics. So the way we'll start is we'll have Greg start out first, just to introduce himself very briefly and the work he's doing at Frost in this space. Then we'll have John and then Chris do the same. That way you have a good solid idea about who's on the panel. And then I'll just pose some questions, and we'll have a good discussion over the next hour about how is the business of healthcare going to be transformed using this continuous diagnostic data that we have now instead of the episodic diagnostics that we've used in the past. So with that, Greg, go ahead, jump in, give us a quick intro, and then we'll go from there.
Sure. Greg Caressi, Senior Vice President of Transformational Health at Frost and Sullivan. Well, let's see.
I can hear.
You can hear me?
I hear.
Okay.
Oh, it might just be me. It says other people can hear you. So go ahead.
Okay.
Let me see if it's my problem.
Yep, sorry. Greg Caressi, Senior Vice President of Transformational Health at Frost and Sullivan. We're looking at activities across the supply and demand side of this space in terms of understanding what the market potential is, looking at the wearables and sensor side of it, and looking at the business case side of it. And my first question back when we get started will be, are we talking about patient-generated health data or person-generated health data? So maybe I'll hand off to you, John, since your organization is looking at person as opposed to patient, and see if there's a difference there.
Okay. I didn't know I'd get a question.
Yeah, sorry. You don't have to answer. You can do the intro first.
That's
we'll
okay.
Come back to that.
All right. I'm John Sharp, Senior Manager with the Personal Connected Health Alliance of HIMSS. And we've been trying to understand this space for a while now, and have some things on the HIMSS website describing it, including a recent blog post by Chris. So I'm not sure. Well, we're trying to move away, I think, our group at least, from just the patient focus, because a lot of this data does have to do with persons, as Shahid was referring to, living their everyday life and collecting data more continuously about their health. So I think maybe person-connected data, person-generated health data, rather than patient or even consumer, might be the right way to describe it, because it really has to do with overall health and not just illness and not just being a patient. Okay, Chris.
So I'll keep going around. Greg, I love that you're stirring it up just in the introduction. I love that. I love it.
Come in last.
And I definitely think it's around the person, down the patient. We'll talk about that in a little bit more of a holistic view of the actual individual. What Validic does, I run the marketing and business development on a global basis here at Validic, and Validic is the leading digital health platform. We connect data, health data that gets generated outside of the hospital, where 99.9% of our lives are lived. And we connect that data through our cloud-based system that goes into payers, hospitals, wellness companies, healthcare IT, EMR vendors. And we reach about 223 million lives in 47 countries. And so our goal is to take this data and deliver it in a standardized and actionable way to those clients. And we'll talk about examples a little bit more and proof points and really how people are using this data. But that might be for them to be able to, for healthcare organizations to be able to define and run better patient engagement strategies, better coordination or care management programs, population health initiatives, bring drugs to market faster on the pharma side. So we'll talk more about those examples, but it's great to be here. Thanks for the invite.
Great. I appreciate all you guys coming in so I can finally hear you properly now with the headphones. So that was my little tech problem for the day. So what I wanted to start off with was perhaps discuss the idea of patient-generated healthcare data has two major myths associated with it. One, that the data being generated doesn't have that much value, and therefore, meaning to the provider side or the physician side. And maybe, Chris, you can say a few words there, is that I have not seen a company get adopted as fast as you guys have in healthcare provider settings over the past few years. So tell us a little bit about who cares about this data. Give us some either marquee names or people who are connected up with you guys and saying, no, this patient data, whatever it is, patient data, it's only going to grow over time. So tell us who's using this. Is it important? Are people pushing back and saying, well, why are you doing this? Or is it just a matter of fact now that this is?
Yeah, and for those, we'll cover off. I certainly want to be aware of all of the time, and I'll dive into this. We have a bunch of case studies and examples at validic.com/resources that people can take a look at case studies. But I'll highlight a few things. But to your question, Shahid, about why this is important, when you think about the triple aim of healthcare, and from again, these lab sessions and webinars are around the business aspects of it. And this is really, we're approaching this alongside our clients from a business standpoint, of trying to help them improve the experience and trying to improve the health of the populations, helping them reduce per capita. And so one example is, I'll just cite one example, and then we'll kind of keep going around the horn. I could probably spend 60 minutes just talking about proof points and examples of organizations, whether it's Osner, Carolina's Healthcare, Sutter Health, Kaiser. An example would be like with Sutter Health as an organization. For those that are on the call that don't know Sutter Health, they're a 30 hospital health system in San Francisco, Silicon Valley. They had a group of hypertension and heart disease in their patient population, and they were trying to do remote patient monitoring program with this population set. And we all know that's very expensive to be able to care for this population. And so there's an organization that has been forward thinking about patient engagement, but also reducing costs, also thinking about a program that could prevent a negative event from happening. So they took this population set, gave them a scale, an activity tracker, and a blood pressure monitor, and just said, go live your life. Just go live your life. All you need to do is, these devices are connected. We'll connect them through Validic, and Validic will then take the data. So that patient who knows they're a part of this program is allowing permission of these devices to be going right to Sutter Health. That data gets normalized and standardized and delivered to Sutter Health. And what Sutter Health does is then they can make some big data algorithms on top of this and some decisions on it to be able to say, do we want this information? What do we want to do with this information? And so what they've done with it is they've said, okay, well, we're seeing certain trends. Mrs. Smith is not moving very much. Her readings are slightly off. And so they can build those trends out, bring those trends into the EMR if they decide to as a business rule. But what they're doing a lot, Shahid, is they're taking their notification to the caregiver. And the caregiver's picking up the phone and they're calling Mrs. Smith, or she's sending a text to Mrs. Smith, and they're saying, Mrs. Smith, I know that your weight's been fluctuating up, your activity's been fluctuating down. Is there a reason for that? And they can do this on a daily basis. They can do this on a weekly basis. And so this program has been very insightful to them, because what it showed Sutter is that this patient population really does want to take more care of their life and their well-being. And they're also able to find some insights into this data, and they're going to start to roll that out into some of the other chronic ill disease states. So that's just an example. Like I said, I don't want to hog the time there, but it's really happening. That's kind of the thing that's taking place, is it's really happening, helping patient engagement, and it's really helping their bottom line as well.
Right. And Greg, from your perspective, certainly as an analyst, you're seeing a number of different requests from customers come in around how they could potentially generate this data, use this data, change their business around it. So talk a little bit about what Chris says. Do you see that Sutter is a anomaly, or are there a lot of companies wanting to do this, some of them in different stages of development, but pretty much everybody moving this direction? Or is it an anomaly in the sense that Sutter is, it's an advanced organization. They have advanced analytics. They're doing things in ways that lots of other companies are not. So are they an outlier, or what are we really seeing in the marketplace here?
Yeah, I think, it's early days still. I think people are very interested, and the attitude has changed over the last 2 years to me among the providers I've spoken with. Is when you go back 2 years ago, patient-generated data, I don't trust it. It's not that valuable. Today there's a much different attitude among the provider community. There's much more acceptance. So we need to figure out how to use it, not, stop it from getting in the door. So the question is how to use it. And I think the reality is right now, the business case, if you will, is around patient-generated data, because it is, as Chris described, being used to deal with potentially high-cost patients, organizations at risk that are trying to manage chronic disease care, et cetera. And a lot of it is still in the pilot stages, or it's in the stage of, okay, we're trying to learn from the data. What can it tell us? What can we do? So I don't think we're at a place where we'd say systematically, we know here's the model, here's the structure, here's what, how we're going to roll it out across the board. It's more of, okay, we believe this data is valuable. We believe it will give us insights, especially around chronic disease care or high cost patients. And so the business model is patient generated right now, not person generated. We'll talk about that shift over time, because I think there is a future for person generated, but it is, relatively early days. A lot of the leading organizations are taking activity, but I think there's interest across the board and to figure out how can we utilize this information. How can we integrate it? How can we then digest it and use it to create value out of it?
And what are you seeing, Greg, with respect to who these organizations are looking out as the people who are going to help them answer that? So they're obviously you're going to Validic and others like Human API to do the connections. Who are they hiring to help them figure that out? Are they trying to do it themselves, or are they coming to analysts, going to the big six? Who are they going to?
Yeah, I think for the integration side, there are a lot of organizations, these leading entities, who try to do it on their own often first. And some of them I know have actually gone to companies like Validic as follow-on and said, wow, this is a nightmare. And going forward, how do we manage this? So they're looking at Validic now as a resource. So I think organizations will, who try to do it themselves will quickly learn that if you're going to really try to make this part of your standard of care and connect all kinds of devices, you don't want to manage the tech side. Stay in your business, which is healthcare, right? So, I think they're going to organizations like Validic and others that offer the platform side of that. On the analytics side, to be very frank, what I've seen so far is mostly healthcare organizations doing it themselves, coming up with their own algorithms, trying to learn, as Chris described, and doing that part on their own at this stage. Although you start to see partnerships come into play. SAP is doing something with Stanford around cardiovascular to try to collect data, learn from it, and then develop a solution. So there are activities and partnerships between vendors and some of these leading healthcare providers, but the leading healthcare providers often are looking at doing the analytics side themselves at this stage from what we've seen.
Great. Yeah. So John, when you look at, what an innovator like Chris and Validic are talking about, as well as a person who really understands the industry very deeply, like Greg has said, is what they said matching with what the expectations at HIMSS was? HIMSS has been around for decades trying to solve these kind of problems. When something new comes up, get people together, which is it's a monumental task normally. Just getting us together on your biweekly calls is often tough. So what are you seeing, John, in the marketplace with respect to the needs that either providers or health systems are coming to him saying, please help us with this? What is the this here? Is it just a matter of having conversations? Have you been asked for specific things to come out of the work groups and others that you're leading? What are you seeing with the asks? What are institutions wanting from HIMSS to help out here, especially with the Personally Connected Health Alliance as well?
Yeah, well, I think there are several things. One is that they're trying to understand or they're motivated to look at it based on the changes in incentives. And those incentives, of course, are the shift to value-based care and population health management, as well as some of the other programs coming out of CMS to hip and knee replacements and the like. So the incentives are headed in the right direction. Then it's a matter of, I think, what people want what are the best practices. They're willing to look at successful pilot studies. I think there's some questions about scalability. How large can this go, particularly in populations like diabetics or pre-diabetics, which are usually a lot larger populations than, say, congestive heart failure or some of the others. So they want examples of best practices. How did other organizations do it? And then how they can build on that experience, or who they should talk to, how they're developing algorithms. I think that's a real challenge. Although I think, in addition to what Greg said, I think some population health management companies are beginning to look at this as well. I don't have specific examples, but I think they're at least moving into that area.
Yeah, and I think just to follow up on that, if I would, I think right now that's the challenge: is how do you create actions and output or outcomes out of this data, and that's why organizations are experimenting. But part of that scalability question that John referred to is, we do need IT organizations and systematic approaches so that we can change the model under which we're using this data. These are huge volumes of data. It requires a lot of sorting. Scalability requires solutions like Validic so that you can, scale all the types of data you can collect from, the wide variety of devices that are out there. And then how do you consume it? How do you act on it? To me, if we're saying it's going to be a human follow-up based on, some kind of alert system, that's probably not scalable beyond, very high cost or, chronically ill populations. So if we want to use this in a more broader fashion, as we go towards maybe capitated care and say we want to make it person-centric and broader, we really have to leverage artificial intelligence platforms, be able to consume this data, create alerts that are more machine acted on at first, reaching out to the person, trying to collect more information, not giving it to somebody to make a call, but saying, hey, let's take a first action to validate what's going on, see if this is real, get information back, and then accelerate or escalate maybe up the most extreme cases for people to call. But others have to be done through other methods, virtual coaching, outreach to the individual around taking medications or whatever activities might need to be done that can be automated. That's really, if we don't bring automation, artificial intelligence into these solutions, I don't see that it is scalable over time.
Just to build on a comment that John and Greg made, Shahid, what was interesting is that when talking about scale and talking about focus and talking about a lot of this, what we've been seeing, and I was just in the office of a national, it was a very big brand name of a hospital health system 2 weeks ago. We would all know this by name. And they said something to me that I was not expecting. And they said, we're kind of going through a lot of change management. So much of this with patient-generated health data and adopting this and using this is a lot of change management that I need to sell internally. Okay, so even though we have these chronically ill disease state patient population sets of diabetes, hypertension, heart disease, etc., I need to actually focus on one of them right now and do a program around one of them. Okay, and I'm taking our diabetes state and I'm going to say, okay, they're going to get something else soon as it relates to this connected health type of program, but I'm going to prove out how this works with blood pressure and blood pressure cuffs and the data that's coming off of that. And I'm going to do that. And we're going to show how that data flows, how it streams through, how it can go into the clinical workflow or not. Okay, let's put some business rules around that. And they said, that's what we're going to do. And we're going to do that really well. We're going to sell that internally. We're going to educate our organization really well. And then, per Greg's point, some of those things they could layer in AI if they want to, but then that tees up the next step for scale. And so much we're seeing is there's a lot of internal change management principles that organizations are starting to use around this topic.
So Chris, as a follow-up there, so there's two parts of the question for the next few seconds that we'll talk about. One is pretend like your boss is not watching this or will ever see this, Chris, and tell us what is not.
I thought I report to Greg and John. Greg and John are my boss.
That's even better. So
I'll close my eyes and turn off my headset.
There you go. So tell us, Chris, what are you seeing where people are making mistakes getting into PGHD, and they shouldn't really be doing X until they've already done A, B, and C before getting to the PGHD side. Because I think what's happening is sometimes it's a shiny new object, and we all suffer from shiny new object syndrome. So tell us where you think, so you've told us Sutter and others are doing it well, and maybe if we go and dive in a little bit deep, they're making certain mistakes or they made some mistakes in the past. You don't have to mention any particular customers, but what are people doing wrong when they're thinking about PGHD? And then we'll talk about what does a proper way of doing PGHD look like, and I'll orient that question in a second after you tell us what people are doing wrong.
Yeah, good question. So just again a context comment, which is we have clients from entrepreneurial clients to emerging clients to enterprise clients. They're all different shapes and sizes. And they're in hospitals and health systems. They're in pharma companies. Okay, I could talk a lot about pharma, but they're wellness companies. Okay, there's EMR vendors, and so there's all kind of different triggers and pain points and challenges and obstacles and mistakes that these companies have made. So, but I will focus on one is that defining the use case. Okay. Is something that some people are not doing properly, okay? And they might not have it completely defined, but if they might have, for example, if it's a population health organization, are they working closely with a couple of clients, whether it's hospitals or organizations that are thinking about ways to be able to use patient-generated health data? Okay, could that be remote patient monitoring? Could it be in preventing readmissions? Have they truly thought about the use case? Again, we have use cases to the cows come home based on the stuff that we're doing. But when we start engaging, Shahid, we ask that question a lot because some people haven't really thought through. And so we kind of have to come alongside these organizations every day and say, here are some ways that some of our hundreds of other clients are using Validic and thinking about patient-generated health data. And so that works. And then the other mistake that we see all the time, and Greg already mentioned it, is these organizations try doing it themselves, and then they start going down a path and say, I'm just going to connect a couple of devices to see how that works, and then they wake up and it's kind of funny. They've given me one of these organizations says it's the what the heck are we doing moment. Chris, I had the what the heck are we doing moment. Why you at Validic do this for a living? You guys do this, best practices set up. So why in the world? I'm providing patient care. I'm providing, trying to manage my population. I'm trying to manage my margins, at a hospital. Why in the world do I think I want to deal with device connectivity and maintenance and all of that? I just need the actionable data to run my key business initiatives. So we do see that, and Greg's exactly right. These organizations, some of them try it themselves, and they're like, that's not the core business I'm in. Go Validic, great. When we're done, fantastic, easy. So
no, that's a good point. And there's some questions on the side. We'll ask them in a second. I think so. Chris, we'll come back to you in a second and ask the question that gives some concrete examples of use cases not related to client conditions. But before I get to there, let's look at what a proper use case of PGHD might be across institutions. My thesis, and something Don and I have talked about a lot on HCBiz, is that a lot of the future problems that we're going to have to solve over the next few years are more about multi-stakeholder, multi-institution. So is it, are the PGHD use cases better to start within your institution, or should you start with use cases where you're trying to take the same patient, but collect data and share it across multiple institutions? So, for example, Validic is somebody who can do that already. There are others who can pull together this kind of information. So, John, as you start hearing from members at HIMSS, is this use case something that people are thinking about, the multi-institution one, or are they mostly really talking about their own problems? I need to get that data for my particular use cases, not me connecting up with 2 or 3 other downstream providers. And then we'll have Greg comment on that as well.
Yeah, I think since we're in the early stages of this still, I think most are just looking at their own organizations. Now, those like Sutter and partners in other places, they these are multi-institutional health systems, so they are looking across the health system, or they may look within a certain specialty within that health system, again, whether it's endocrinology or cardiology or whatever. So, but I think we're still at that point, sharing data across. Of course, interoperability is a problem already, and in this area, no less than that. But at least if you have standardized data, or if you're using the same vendor, then you can share it across health systems, and that'll be more important as we get into population health and you try to follow patients across as they're admitted to an emergency room in another hospital. That's not part of your system. So I think it needs to come to that. I don't think we're ready for that yet, but particularly, again, the context of population health,
so
need
Greg,
to be ready for that.
In this case, as Chris properly pointed out, the use cases matter, and you get the wrong use case, no technology is correct. You get the right use case, sometimes technology doesn't matter. The use case will point it to the right direction. In this case, the thesis that I'm making is that pop health is about a population, and it's not an institutional pop health. It's not like institution 1 has a population, then institution 1 has their own population, then institution 3 has their own population. And then when we connect those up, things will work out really well. That's just a crazy way of thinking, but that's unfortunately where we are today. Could PGHD and offerings like we do have centrally managed from folks like Validic or Human API and others, could that be allowing us to finally treat populations as real populations? Like the diabetics in this zip code are the population, and the 100 companies that have to work with that population can connect up together using PGHD as the starting point, instead of hoping that an HIE in the future will help solve these problems. So is that a worthwhile?
Yeah, I think you're on to something in saying you could build it to where it's a shared infrastructure from the get-go. The reality is, again, right now we're plugging into sort of existing solutions. So most of the efforts, I would tend to agree with John, are, keep it simple, stupid. We're going to deal with we're in the political season. So, we're trying to just.
As long as you're not calling me stupid.
But, the idea being, this is something we're just instituting within a department in many cases. And, the other side of making it multi-organizational is, I think the bigger challenge here is not the technical challenge in the end, it's the culture change challenge, right? It's what do we do and what happens with this info and how is it acted on by the organization? So that's a culture change to put into one organization. Now you're going to say you're going to put it into several and have them all act in concert. It's tougher to execute, right? And then there's the culture change of how that ends up being, in some action by me, the person, right? So I think, we've got challenges there on the culture side that require us to, in a way, start somewhat slow and learn how to do it and then move from there. Because, that systematic change that we've been talking about a little bit all along is probably, it's a driver. And it's also a restraint, right? Because systems change slowly, and not just IT systems, but.
Yeah, you're so right. So when you look at the three big things that we're looking at over the next few years, again, in that multi-institution, multi-stakeholder world, is pop health, care coordination, and patient engagement. Those are all facets of the same thing in general, right? So if you buy the argument,
they're all culture change as well, right? So that's part of. But
that's what Chris was saying about change control. So tell me a little bit, Greg, here. Could it be, and this is now I'm asking you to put your analyst hat on and say, let's think about the future and the right way, because John, I think, rightfully mentioned that people are looking for best practices. Could we make the argument that the best practice for the best way for you to use patient-generated healthcare data is work with 2 or 3 organizations together, because that's the first place you're going to get shared information. It's coming from the patient, not from institutions. And as we know, institutional medical records are really hard to share because there's a data ownership problem. In this particular case, if patient-generated healthcare data can be qualified as the patient's data, no institution could possibly say that data belongs to them. Could it be the starting point of a better healthcare interoperability scenario. And again, just a starting place, not where we're going to end up. But if we said to ourselves that pop health is important, care coordination is important, and patient engagement is important, none of those are possible without multi-institution, multi-stakeholder, and PGHD could be the railroad tracks that take us. You still have to put the locomotive on there. What that locomotive will be could be population health.
Yeah, and what part of that driver could be viewing. Right now we're in the stage of viewing person generated health data from the clinical viewpoint solely, because we're trying to prove the clinical case and understand that. Part of what you're talking about could also be driven by the business case / competitive scenario, right? In a couple of years, I think you're going to see cancer patients demanding that you figure out how to run my genome. I'll pay for it if I need to, because that's important to my care. Cardiovascular patients, should they be looking and saying, okay, who is offering to track me on a more consistent basis? And is that the provider I want to sign up for because they have a better solution for me as the consumer, right? So I think, part of how this shifts over time is also, is it a competitive advantage? If it's a competitive advantage, now you have organizations wanting to join in that alliance and saying, we got to figure out how to be part of this. And these guys over here, this big organization with great IT staff, has a solution that they're implementing. I want to be a partner in that. I want to be part of that, care coordination and figure out how I can consume that data. So I think, part of that also comes from the patient side, as well as people start to look, this is one of the big drivers of patient-generated health data, right? Is there's the clinician side, and a lot of clinicians are trying to get into it. There's also the person side, because a lot of people are trying to figure out how to use their own data as well. So, there is a competitive advantage that I think organizations will see over time as these solutions become a little more mature and they understand that it is valuable data. And now I can say I do that, and does my competitor, hospital B, do that? Does cardiologist C do that? Now the world starts to change.
Yeah.
Shahid, that's a really good point. We haven't, Frost & Sullivan's done some great work as far as thinking about markets and where markets are going and thinking about behavior. Greg and his team have done some great work, but this is a really important point, because we've been on this call, and we really haven't talked a lot about the person, okay, the patient, the consumer, okay, and what's their relationship to this incredible transformation that's taking place in healthcare, okay? They are a key part of it, just like Greg outlined. I mean, they are fueling. I mean, you just think about over the last several years, people using WebMD, using like Patients Like Me sources, people printing out, going to Google and searching, all of the information and bringing in reams of paper or showing, reports on their phone to the doctor when they walk in. And here you have all these consumer device manufacturers like the Apples and the Googles and the Samsungs, and they're all building these, they're fueling a lot of the consumer thinking and adoption and getting people to think about their health a little bit more. It's a very exciting time right now, and we are seeing that take place. And I completely agree with Greg that the consumer, that individual, that person is playing a more important role in the demands. And the fact is, whether we in healthcare like it or not, consumers are expecting to interact with their doctor just like my daughter does with Snapchat. And people are posting on Instagram and Facebook posts, and they're just expecting an experience like what they see in the rest of their life. And why can't that be in healthcare? And again, I think if you end up looking at kind of the future of healthcare, look to the millennials on how they're interacting with technology right now. Okay, I don't know
Chris,
about you.
Let's talk about that. I think that's a great point. So one of the reasons why it doesn't happen in healthcare is this multi-institution problem, is that your care is managed by multiple groups of multiple stakeholders in multiple institutions, not by one institution. So I think the simple examples are great, but let's dive a little bit deeper and say the things are the way that they are because of our incentives. And I think John started talking about where the incentives are going. If the incentives are going towards value-based care, and the only way to have value-based care is to do it collaboratively across institutions, does it make sense then that PGHD is a driver towards that multi-institution collaboration so you can get to value-based care. Because I think the fundamental problem of any particular institution trying to add on whatever technologies that they want, it doesn't matter whether Sutter Health has the best technology, Sutter is not the center of that patient's life under any circumstances. So that's what I'm hoping that institutions start to see this as a mistake, to say that if we don't choose PGHD as the locomotive that's going to help us to get to value-based care, as a locomotive to help us to get to collaborative care, that we might be missing a major opportunity, because we're all complaining about data.
Or maybe you're also, you haven't mentioned one. There is one organization that we all individually have one of that manages our care. Payer, right? There's only one payer. You got, right? We all have one, and Chris, I don't know if you got a sales team selling into payers, but that's one group. Now, do I want that information going to payer? That's a whole different question. And maybe there needs to be an interface there, a third party. But that's the one. That's the single for each one of us individually.
So let's, John, can you bring up the so during the PCHA, I think we have a Personally Connected Health Alliance a forum coming up later this fall. And near that time is also the cybersecurity one. This is a good time to bring up, so David Harlow and Don both asked about a couple of different questions on the sidebar there. So from a privacy perspective, what kind of questions are you seeing from industry participants, John, where is privacy or security or anything holding up further progress on PGHD, or is that not a big deal for now?
Well, I think there's some concern that some devices particularly can be hacked, but there isn't good evidence of that yet. I think the privacy concern might come more from the patient or consumer or person, and their who's getting to see their data. It is a problem in terms of third parties getting the data. Does your device company, your activity monitor company sell your data to a third party? And there's very little control over that. And that's where I think there needs to be some changes in HIPAA or other federal regulations to control that. However, I think part of the solution, both to population health and this security issue, is if the patient has control over who sees their data, whether that's, it's kind of this patient-controlled HIE, if that's possible, and a lot of people have proposed that in the past. And can that also be true of this data, that the patient says, I'll give permission to these physicians in these different practices access to my data, because it's important for them to be able to manage my health. So I think that the privacy control should come back to the patient.
Right. So in this case, then, Chris, let's answer David's first question, which is examples of use cases not related to chronic care, and if you can weave in some of that, if you have some examples there to talk about how does consent work today with Validic. There's like if I push my data to Validic, there's one of me. Multiple institutions are connected and they can all see my data together with bits and pieces of it? Or how does that work today? So if you can answer David's question along with that, that'd be good.
Yeah, I think that's certainly the latter is more of a technical question, and I know you want to keep this high level business, but I'm happy to answer it. I think the question that was asked on the sidebar about, first of all, why have we been talking about so many chronic condition use cases? Okay, because it's $1 trillion problem. Right now, okay, and if you look at some of Frost and Sullivan's great kind of trending, the wellness companies, the wellness market is a different market, okay, that's not growing as fast as the all the chronic diseases. And where does all of the technology, how can it help? And this is in the chronic disease state management, right? It is really $1 trillion problem. So if there's a lot of talk about it, and there's a lot of work on it. There should be a lot of work on it because it's a big problem, and technology and patient-generated health data can help that. So specifically, so moving per the request, moving outside the chronic state, let's go to wellness for a second. So we have several wellness clients, and you think about wellness who are actually working with employers who are running employer challenges where they have their employee bases using devices. The data will go through Validic. The consumer is allowing, that employee is allowing that device to go into their employee challenge. The employee challenge is providing rewards for fitness and certain challenges. We just fueled a national On the Move challenge with a nonprofit organization called Wellcoa. They had a few 100,000 people who, it was bring your own device. They were using their own devices, and this was trying to get companies to be more fit and be more active. And this was a 12-week big challenge that we just finished. I'll move over from wellness to pharma for a second. And so we work with several of the large pharma organizations. One of the companies that we work with is Proteus Digital Health, and they make an ingestible sensor. Why do they, what's the business problem? The business problem is medication adherence. People don't take their medicine, right? Only 37% of people actually fulfill their medicine protocols. So this is an ingestible sensor that goes down with the pill. When it hits the stomach, it actually activates the sensor, which is a patch is being worn, which then goes to an app for visualization of the dashboard. That consumer can see it. That doctor can also see it on a dashboard to see, is this patient active? Have they taken the medication? This radio sensor is like the size of a grain of sand. Very cool technology that Proteus is doing. And so, but they're trying to take a look at that and take a look at not just did they take the medicine, but how what were they doing with their lifestyles, the social dynamics of their life, the fitness and the well-being of their life. Again, not necessarily about a chronic condition per se, but this is helping to be able to tackle medication adherence. And so those are just a couple of examples. Again, we've been talking about hospitals and health systems a lot. I just kind of teed up a couple of wellness examples, and then Proteus is a pharma. I could go on, Shahid, but you're going to need to extend this thing 60 more minutes. So,
and then tell us about the consent side, because that ties in with these use cases.
Yeah. Yep. Thank you. So just to be really high level specific, and I'll go back to the Sutter illustration where they have been told by their doctor and through that relationship to say, Mrs. Smith, you are participating in this hypertension heart disease program with your doctor at Sutter Health. Okay, Sutter Health has an app that is, they say, Mrs. Smith, you already have a phone. Great, download the phone or the phone app, or you might already have the patient portal app on your phone. Great, very simple. Mrs. Smith goes into her app. She's able to see which devices that she wants to connect, the ones that are connected through this particular program using Validic and Sutter Health. Validic, again, is a cloud-based technology behind the scenes. It's very frictionless and seamless. So Mrs. Smith says, oh, I see my Sutter Health app. I see which devices I want to connect, activate and go. All right. And all of her data is able to go through standardized over to Sutter. We have some different algorithms and technology that we use to make sure it's de-identified and HIPAA compliant, which all the data is. And so that gets into another technical, flow chart, which we can talk about maybe on another, a technical blab if you want.
Yeah, no, that's a good point. So just as a final point there, and then for the last 10 minutes of the call, I'd like to talk a little bit about the innovation side of what's coming up. So if you look at then that example of the Sutter, so they have their own Sutter app. I, as a patient, saw my Sutter app. I connected up. Now, let's say that Greg has a great idea for another app, wants to work with that same Sutter population now. What does that look like as far as Validic is concerned? Is that Greg has his own app and John has his own app, but they can connect to that community? So the examples that you gave, how does that work? No,
I'm assuming you're saying John's at a separate entity, Greg's at a separate entity. They can't access Mrs. Smith's data.
Okay, so in this case, and that's from a policy perspective or from a technical perspective?
No, that's from a, do the right thing policy, HIPAA compliant perspective.
No, that makes sense.
Okay.
And so that means that if Greg and John got together and went to talk to Sutter, they all agreed that yes, let's manage this patient together. They would be able to open it up, meaning a Validic would be able to allow them to share that data if they got the policy part connected.
If it's again, this is the consumer's data, okay? Right? This is the relationship. We don't get into the way of that relationship, with the exception of delivering data in an actionable, meaningful way, right? And layering some additional insights that the Sutter Health or the company can act on. If Sutter Health wants to then say, hey, I want to go off and use some special analytics tool or engine and use this data that's outside the four walls of my hospital, then that's up to them.
Got it. Okay, so let's now talk a little bit, maybe Don and Greg, tell us what you're seeing as far as asks from customers, where we could talk to, remember that a lot of the audience that we have are innovators, they're system builders, they're business people who would, if you gave them a cool idea, they could go implement it and make it happen next month. What should we be telling these guys to look at? Which angles do they look at? You've got a foundational capability with Chris, as far as Validic is concerned. What, Greg and John, should we be telling innovators to go and do that might be missing in the marketplace?
Right. Well, I think one thing that's missing, and this has just come up recently, is the consumer type devices are beginning to show, there'll be some new studies showing that their lack of reliability. So I think part of what needs to happen is we need consumer grade devices that are moving toward the reliability of medical grade devices. I think there are some security issues that need to be dealt with. And then the other area for innovation, I think, is always there, and that is there are new types of sensors coming out every week. And how do you integrate those, and how do you show that they have value in the clinical setting as well as value to the consumer?
Yeah, and from my seat, I think we need to work on the application and intelligence side of these solutions to create more of that automation. So we talked a little bit about that. But then the other side is the value proposition, because these solutions above all won't work if they're only creating value for the providers, right? So we've been talking about providers and pharma, et cetera. These are the customers, right? But in the end, these solutions have to create value for that customer, but also for the person, because we all know, how quickly the turnover is on wearables, and it might be a wearable that sends the info to my doc. If I don't see the value over time, do I keep using that device, right? And that's where, again, in early stages, it's hard for us to gauge. The feedback from the consumer side has been good in the pilot stage, but we haven't had mass deployments. We haven't had these things out there for 2 years to see, do people keep doing this? So I think one of the difficulties of these solutions is you have to create value for different stakeholders, and the consumers are one of those stakeholders. And I think that solves a lot of problems. One, it solves is this a sustainable business? Is this going to be a sustainable flow of information? It addresses the privacy issue. I know I've seen a lot of comments on the right sidebar about privacy. But we all know that we'll trade off privacy for some perceived benefit that we get, whether it's in our finance, whether it's in our internet use, whatever it is. We make those trade-offs every day, right? Every one of us, and our kids do it at a level that is, exponentially higher than us. So that's the next generation that is going to be the consumers of these devices. So I think, if we create value for the consumer, a lot of problems are solved. The last thing I would say is if somebody wants to sign up and give me a share of their company, I think there's a consumer solution. What about analytics to the consumer? That, to me, that is not far away in a lot of these areas. And I think, the unifying platform in the end might not be the medical record or even owned at the provider side. It might come from that third party who might start by, hey, I'm going to create a solution that creates value for this group of people, and I'm going to sell it directly to them in some way, or I'm going to figure out how to monetize it through secondary use of data that I get them to approve, and create value for them that, creates that business model. So I think there is an analytics to the consumer model, and that it will develop in this space above all, because the early adopters here have shown a willingness to pay and to, interest in figuring out how to track their devices. We've got platforms that will help us do that already. And, that's maybe happens outside the US first because of HIPAA or because of the FDA. But it's going to happen within the next 5 years.
Hey Shahid, we're going to have to wrap this up quickly because Greg and I have a separate business that we're going to go off.
He doesn't want me to talk anymore. That must be a good idea.
Well, it's that's funny just because of my earlier point about consumers and how important they are as they're key drivers of this. I mean, just to build on that thought about, you think about the caregivers. We have the aging population. We haven't mentioned that at all today, and it's such a dynamic to the business and transformation of healthcare, and using patient-generated health data to share. I mean, we are in a sharing social society now more than ever right now, and to be able to see, did my mom take her meds? Was she active? And just being able to have that, and she lives across country. I mean, just there's continuing, if we continue to provide value to the consumer, and they understand that sharing their data and what they're getting back, is a great benefit. And I just, if anybody is wondering right now today, if, consumer technology and wearables and phone apps, is not going to change healthcare, then people have not paid attention to Pokemon Go over the last two months. Okay.
Yeah, that's a great point, Chris. Although let me put a challenge, especially out to companies like Validic, and I've done this to our friends and colleagues at SureScripts as well. These networks and platforms, of which you certainly are a member. So the big problem that we're seeing as far as the innovator community is, for innovations to truly happen, a challenge has to be given to folks like SureScripts and Validic and others who have this network to be able to say, I'm going to create a marketplace that allows third parties to come in. So the idea that Greg has right now, if the APIs and a marketplace and consent management, et cetera, were available through Validic, Human API, SureScripts, these other very large platforms that have millions of records on them, and they opened it up, then I think you guys can start to foster the things that you're talking about. It's really hard for the smaller vendors, the smaller innovators, et cetera, to go do things, because I gave you a very simple example of just Greg and John connecting to Sutter, and it was a complex answer, and it should be complex. I mean, we're talking about patient safety, we're talking about patient privacy, all kinds of good reasons. But this is where maybe talk a little bit about where is Validic going.
So we have one. So Shahid, maybe I can tell you more about. It's called Validic Connect. It's been around for a year, and it allows people to innovate and build on this. For example, there was a small company that saw that 30 million people suffered from depression in the United States, and they had clinical studies that said, if we expose them to more sunlight, if somebody gets exposed to more sunlight, that depression goes down. Okay, so this was something that, again, part of it's called Validic Connect. It's a marketplace that's open for people to innovate on, whether they're devices or whether they have technologies or whether they're apps. It's completely running and functional, and people are using it and building it on all the time. So I can tell you more about it, offline if you want to provide a little bit more insight on how it works. But this is happening. People are innovating to it every single day.
Great. Yeah, that's the piece that I wanted to really conclude with here is the idea that that innovators working one by one with institutions is going to create some leapfrog in capabilities is not going to happen, right? We have to have these platforms in every other industry. When we've had leaps, it was because a platform was created and then people built on that to get the next leap. So an Uber is not possible if an iPhone doesn't exist. I think that's the key.
Perfect example. With, I don't know if I have time. I have to give you an example.
Yeah, just one minute left.
So Cerner, electronic health record, right? Large organization. They had a lot of organizations, small companies coming to them and want to innovate and deliver information into their EHR. Cerner came to us, and they're a client of ours, and they said, hey, you know what? Don't come to us. We can't handle all that innovation as a large company. We have a lot of priorities, but go to Validic and build into their marketplace and into Validic Connect. That's how you get into Cerner, all right, as an example. And so this has been successful over the last year and a half, but that's allowing us to foster and kind of look at healthcare and the ecosystem at a much larger scale. Instead of, squashing innovation, it's providing, an openness in a community, to be able to foster that innovation. And so that's been successful. That's just an example that's working well. We can talk more about it another time too.
No, that's great. So I really appreciate Greg, John, Chris, all of you guys coming here. We're gonna have to have this conversation around PGHD several times a year. I mean, the stuff is moving along so quickly, and around this idea of the business of healthcare platforms and other areas. I know that a lot of the folks that are on our audience now do talk about this. Just recently, we've had I don't know if you guys have read the new article, the 95 Thesis in Healthcare. I mean, there's a lot of discussion around the kinds of platforms that are necessary to make this happen. And although and so having a public view of technologies like Validic and SureScript and others that have a ton of data, if other innovators have ideas, let's bring them on here. Talk to guys like Chris and bring them on public forums and say, well, what could we use? What could we make available? Because there are going to be 100 things that people are asking Chris and Validic to do now, which they can't do because they're in one business. There are things that could be put into the marketplace, new ideas that could come out that I think would be very beneficial. But one thing I'd like to leave everybody with here is that our core problem is going to continue to be this institutional view of the world. You have to go to the personal or the patient view of the world, number one. We have general agreement on that. You have to say that PGHD is one of these new things that we didn't have 5 years ago. I mean, this wasn't a conversation that you could have in 2010, let alone in 2005. Given that wasn't the case, what can we now do to get around this idea of data blocking, get around this idea of health information exchanges, all the stuff that's legacy, institution to institution, can that be obviated given PGHD? So where can we go for the next 5 years using the patient's data at the forefront instead of the institution's data? That's a very sophisticated problem, one that can't be easily solved, but I think it's worth us discussing over the next few months to see are there technologies and techniques, especially given new platforms, that will allow us to make that shift without having to break legacy, because it's so hard to do in healthcare. With that, again, let me thank the entire panel. And of course, this will be recorded. It'll be put up on YouTube and then made available for viewing later. And then Don and I will be back in touch with each of you to see when we can get you back and continue the conversation, because there's a lot more of the topics that we didn't.
Thanks, guys. Thank you.
Thank you very much.
Good day.
Take care.
Okay.
Have a good one.
Thanks.